Welcome, everybody. I can't believe already we're back together again. It seems like we were just here, but I'm glad that we are. We're here for session 2, how to screen for and identify patients with CKD. Some of this information you may possibly think about being a little duplicative, but we're going to get really in depth today about the screening process in identifying those patients. So you're going to learn even more. It's a great topic area, and I think you're going to find the information extremely helpful. So as before, I'm going to ask you to put your name in the chat. I know you've done this before, but it's going to take a bit for us to get to know each other. Please put in your title, your clinic, organization, your location, and it's okay to, again, share with us why are you participating, because perhaps since last week, maybe it changed. Maybe you have some new ahas. So feel free to chat that in as we go along. Today, our session objectives are know what test to order to identify chronic kidney disease and the diagnose and stage CKD based on testing. We're going to be giving you some additional tools today, and you have not received them, but you will receive them yet this week. And we'll also put them in the chat so you can take them back with you right away, but know that they will come to you in a couple ways in the next few days. So again, here we are at our session format. We start with a welcome by having you chat in and making sure you're in the right place. We will have a polling question, and then Dr. Campbell will go into the presentation. And as you know, we sent you the session materials prior to this week, so you could take a glimpse of them and just kind of get to know the material so you're ready to not only receive his information as he speaks it in the presentation, but also so we can dive into a good discussion so it's not too new to you upon arriving today. And then after that, we're going to get a little bit more in depth today with the action plan, and I will share with you our group space where you can have some ongoing conversations as well as find the materials from each and every session versus having to dig through emails and such and wonder where the heck did you put those things. So I'm just going to pause for a minute and have you just keep chatting in, because that's really helpful, and then I can take a quick look at it too. Okay, so before we start and have Dr. Campbell jump in, Dr. Campbell, because some folks may not have been here last week, and it's always a great reminder, would you please, before you jump into your presentation, please reintroduce yourself and give us a little bit about your background. And then you can keep going and I'll move your slides.
Thank you so much, Mary. I'm Orville Campbell. I'm the Vice President of New Business Development and Strategy for Improve Health. I trained at Emory as an internist and a nephrologist. I've done a lot of work in CKD and practice over 25 years. I work with DaVita as a medical director for 22 plus years. And I've done a lot of correctional work. Developing chronic disease registries. So CKD is near and dear to my heart. And not everyone likes the CKD portion. It's of nephrology. It's very hard work, tedious work. Some may just like the dialysis end, but the dialysis end must work with the CKD end. So in the unfortunate circumstance where someone has to transition from CKD without dialysis to needing dialysis, it's very important that transition occurs smoothly where no one falls through the cracks. Thanks, Mary. All right. How to screen for and identify patients with chronic kidney disease or CKD. Again, let us remind you of the definition of chronic kidney disease: abnormalities of kidney structure or function, and it must be present for at least 3 months or greater. One or both of the following must be present for greater than 3 months. Markers of kidney damage, again, GFR less than 60. Next slide. It all begins with a very robust history and physical. Someone once told me, if you as a physician stop talking long enough, the patient will let you know what's wrong with them. And a lot of times they'll give you family history that you would know to ask. So it begins with a robust history and physical. And again, listening is important in all relationships, whether you're talking about romantic relationship or healthcare relationship, you must listen. That's really important. Complaints, with the appropriate history, past medical and surgical history, especially those areas such as diabetes, hypertension, even acute kidney injury, as well as collagen vascular disease, such as lupus. Social history, self-evident, such as both illicit and illegal drugs. Smoking, as well as sexual history. Why sexual history important? Chronic hepatitis C and hepatitis B could impact kidney function. Again, family history is important, such as collagen vascular disease, especially diabetes and hypertension. Why do we keep saying diabetes and hypertension? Because those are the two main reasons individuals end up on dialysis. Diabetes being number one, hypertension number two. If you're Black or African American, hypertension is number one. Medications is so important. Did someone just start an ACE inhibitor or something like an NSAID that could impact the kidney function? ACE inhibitors and ARBs can, angiotensin receptor blockers, in other words, can lower the GFR. It's important to do the review of systems. It's sort of like a catch-all area, what you fail to ask and what the patient fails to disclose. The reviewer system usually catches, and of course, a robust physical exam. Next slide. Risk factors, you can see them listed there. I'm not going to read them all, just to point out a few. Once again, it's important we need to know about the family history. Abnormal kidney structure, such as polycystic kidney disease. Age, there's a natural decline in kidney function. Once you hit the age of 50, the kidney function decreases maybe around 1 ml per minute per year. However, that's not as rapid as our concern, which is 5 mils per minute per year. That is considered a significant steady decline. And of course, inappropriate use of both legal and illegal drugs. Next slide. Prevention. It's important that we follow the direction of anything that's non-prescribed or the so-called over-the-counter drugs. We have easy access to drugs like ibuprofen and other NSAIDs. So it's very, very important. We tell patients to use it as per product insert. However, there's some drugs that if you have CKD, you really don't need to use, such as NSAID, unless it's absolutely urgent or necessary. Maintaining a healthy weight, being over the ideal weight, the more over the ideal weight you are, the more your kidneys work. So that could cause a loss or decline in kidney function over a period of time. Of course, smoking affects blood vessels of the body, including the small blood vessels of the kidneys, and can cause atherosclerotic damage, excessive inflammation, et cetera, et cetera. And also managing your medical condition to make sure that your A1C is appropriate, and also to make sure your blood pressure is in the appropriate range. And also obesity, to have a plan, a dietary plan, an exercise plan for that individual to trend towards their ideal body weight. Next slide, please. This is one of the standards of screening for chronic kidney disease, is the urine analysis, making sure you look at the color, which should be clear. I'm sorry, the color, which should be straw. What is straw? That's probably something like cheap lemonade, where you can see through it. That's the best I can describe it to patient, cheap lemonade. The clarity, you should be able to see through it. The odor, it should be odorless. However, when people hold their urine in the bladder and it becomes concentrated, especially from lack of hydration, you can have an ammonia smell to the urine just from the acids and other waste products in the urine. Also, certain foods can impact it. Doesn't mean chronic kidney disease. Anyone who's eaten significant amounts of asparagus can tell that there's a distinct odor to your urine when you do use that. Foam should not be present. That usually indicates some types of presence of protein in the urine. Next slide. 9 substances and the specific gravity that facilitate obtaining information on urine health as well as kidney health. You can see them there. For example, there should be no sugar in the urine. If it's there, more than likely could indicate that diabetes is present. Specific gravity, if it's elevated, may indicate that you're dehydrated. pH, there's a wide range, but elevated pH may indicate bacterial infection. Nitrite can be reduced by certain bacteria. Leukocyte esterase could be present because of its production from white cells. Next slide. CKD screening, the urinalysis, microscopic exam, you want to look for cells, such as, again, white cells, red cells, or even CAS, which may be white cell, red cell CAS, which could indicate something like an inflamed glomerular basement membrane, which may indicate that you may have some type of acute nephritic disease going on, or you could have crystals, uric acid crystal, calcium oxalate crystals, could be a hint of stones or other diseases. When someone ingests some things like antifreeze, things to commit suicide, or involving alcoholism, you may see certain types of crystals, as well as mucus and bacteria. Next slide, please. Screening for CKD, again, you want to check for albumin to creatinine, that ratio, albumin to creatinine ratio, to detect albuminuria. What's the difference between albuminuria and proteinuria? It's basically the amount present. We won't get into that, but it's the same thing. The majority of protein is made up in the urine would be made up of albumin, unless it's an abnormal protein, such as light chains from something like myeloma. All right, serum creatinine to estimate the GFR is also important, and we'll talk about assessing the estimated glomerular filtration rate, or eGFR, or the percentage of kidney function that you have. Next slide, please. Again, urinalysis interpretation, no bacteria should be present. As you can see in the top row, bacteria present could mean contamination. But in any case, if you have a patient that is pregnant and you see bacteria in the urine, that they're asymptomatic but pregnant, again, you would want to treat that individual with antibiotics. Whereas in the non-pregnant patient, you probably would not take that approach. Again, we talked about leukocyte esterase, could mean the presence of an infection because of the presence of white cells. You do have pyuria, or significant amount of white cells in the urine greater than 10, but between 5 and 10 is also abnormal. You may want to test for other things. Nitrite, again, the presence of bacteria that reduces nitrates. RBCs less than 5. Over that is considered blood in the urine or hematuria. Could mean many different things. Could be anywhere from something is going on in the kidneys, the glomerular basement membrane is damaged, so you're leaking RBCs or red blood cells. It could indicate that you have accompanying CAS, which is a nephritic type picture. Epithelial cells can be in there. In a good urine sample up to about 4, because they're epithelial cells lining your urethra and your ureters. And then there's a pH range 4 to 5.8. Excessive elevation of the pH could indicate a urea splitting type organism, such as Proteus mirabilis. Next slide, please. Thank you. Here's sort of the bread and butter, the basic fundamentals of blood work that one would obtain screening for chronic kidney disease. Of course, the CBC, because we know that a complete blood count that is abnormal could indicate anemia, because chronic kidney disease does affect the production of erythropoietin and could lead to anemia. It could also, in more advanced kidney disease, lead to bone marrow malfunction. So you may have not only a decrease in the red blood cells, but you may have a decrease in the white blood cell as well as the platelets. The basic metabolic panel, or BMP, with accompanying EGFR. As you remember, the basic metabolic panel has sodium, potassium, BUN, creatinine, chloride, CO2 or bicarbonate, in other words, glucose, and an estimated GFR. And of course, albumin, if it is low, could indicate protein loss, or even other disease states such as malnutrition. You do want to get a lipid panel. Individuals who have CKD, they're at risk for cardiovascular disease, and they may have metabolic syndrome, especially if they're over their ideal body weight, with diabetes, where they have a low metabolism and elevated cholesterol and triglycerides, etc. Then cystatin C, which is a protein made by all nucleated cells. It is a good estimation of kidney function because it is not filtered it is filtered, but it's not reabsorbed or secreted. So therefore, if the cystatin C is high in the blood, that means you have a reduction in kidney function. And we'll talk about that in a second. Also, CKD patients with a BMI greater than or equal to 35, or CKD obese female patient, they outperform creatinine-based formulas. We talk about that in 1 second. What does that really mean? Next slide. All right, advanced blood work, which things that may not be as simple or evident, such as an SPEP, or serum protein electrophoresis, to screen for myeloma type protein, light chains, kappa, lambda, ANA, double-stranded DNA for collagen vascular disease, such as lupus, and then complement levels, which low could mean some type of inflammatory kidney disease, such as active lupus. And then your viral diseases, such as hepatitis B and C, HIV, venereal diseases. So therefore, it's important to do that in your routine screens if the obvious does not come, positive in your more fundamental basic blood work and urine work. Next slide, please. All right, GFR, CKD, and albuminuria categories. This is very important. It can tell you the extent of disease. When you look at the stages of chronic kidney disease, you see to your left on the diagram, G1 through G5, G1 being normal or high. What is normal kidney function? Usually between greater than or equal to 90 up to a GFR no more than 130. Usually that's in males, 120, usually in females. Then G2 to G2 is usually mildly reduced GFR, mild CKD. And then you have mild to moderate and moderate to severe in G3A and G3B. And then you come to severely decreased G4. G5 is kidney failure, and most people require dialysis at that point. So you have the severity of the kidney disease here being quantified by your eGFR, your estimated glomerular filtration rate. And to the right of the diagram, if you have accompanying albuminuria or proteinuria, it gives you the severity from normal to mildly increased, moderately increased in the middle column, and severely increased. So you can see when you're in the red zone, we have serious problems here. If you're not on dialysis and you're in that G4 category, G4A3, you can see right there, more than likely you're not going to recover kidney function. So that's sort of a way of estimating the severity of the proteinuria and the severity of the chronic kidney disease, and making sure no matter where you are in the world, the G-score is pretty much standard. So everyone, rather than saying that person has moderate, mild to moderate kidney disease, chronic kidney disease, you can say they're in the G3A category or range, and everyone will know what you're talking about. It's sort of like a smile. It's a universal language. Next slide, please. CKD screening for the kidneys, kidney ultrasound. What am I looking for? I'm looking for size. Big kidneys can indicate infection, such as pyelonephritis, or it could indicate amyloid. Myeloma kidneys tend to be huge, right? So not only the size, but the echogenicity. In other words, they should look kind of dark in color, but when you start to see the snowflake type pattern or a white pattern, it indicates scarring or an increased echo pattern consistent with chronic kidney disease. We look at the cortex, which is the outer part, the inner part of the kidneys called the medulla. So you want a healthy outer part, so you have good healthy filters. And when you see cortical thickness, it indicates a loss of filters. So an ultrasound is really important to measure size, look at echogenicity and cortical thickness. Next slide, please. So we want to track the eGFR. Why does it matter? Because trending is just as important as in any absolute value, all right? So we want to track the GFR versus time. And it's nice to have either computer-generated chart or manual graph scribbled in the chart or scribbled on paper and scanned into the chart, because it's hard to see a trend, especially if the kidney eGFR is bouncing. But just like the stock market, the trend, the individual spikes can be there or points can be up and down, but you can see overall trend spiking up, spiking down. So use a GFR calculator. Should I use CKD epi versus MDRD? Well, I'll say about the Cockcroft-Gault, we should not be using that because it's influenced by so many things, including age and weight, and you're better off using an MDRD or the CKD epi. The CKD epi, however, has found to be better in assessing eGFR in a subgroup where the GFR is greater than 60. It's important to use it with cystatin C, especially while assessing cardiovascular risk. When looking at individuals who may, cystatin C it's also an important thing to use when someone may be emaciated or because they're very frail, so their creatinine is significantly lower than expected. So again, obesity, anorexia, emaciation, malnourished, individuals with a BMI greater than 35 or equal to 35 is important. And female patients over the age of 65, cystatin C used with the CKD epi equation is very important. The MDRD equation, neither of them, we're no longer doing race adjustments, because when you look at Blacks and African Americans, it can hurt them in terms of tracking their GFR, accuracy in that GFR, and also may delay them being listed on the transplant list because it may overestimate their eGFR. So the CKD epi equation, it is superior, it's more accurate. And again, in individuals with eGFR greater than 60, in patients who are obese, i.e. BMI greater than or equal to 35. Why does obesity matter? Because again, obesity falsely elevates the GFR. The other way that cystatin can be used along with the CKD epi equation is in individuals that you really suspect CKD, but they have a normal GFR. For example, we suspect a CKD, you do an ultrasound, you see a whole lot of white or increased echo pattern. So you said, this doesn't add up, let me do a cystatin C. What is a normal cystatin C? Between 0.6 to 1 milligrams per liter. Again, if it is elevated, you expect a decrease in renal function. Next slide, please. How often should you screen for comorbidities? Most annually. However, you can screen more often as you get to more advanced kidney disease. These screenings typically are for normal individuals or mild kidney disease. But when you start to get to moderate to severe disease, for example, when you get to stage 4 CKD, you may want I'm sorry. How much did we miss? I apologize.
Only a few seconds, so.
Sorry, I had a coughing fit and I had to mute and forgot to mute.
Yeah.
So usually you want to screen annually. However, as you get to moderate to severe kidney disease, you may want to screen more often, and you do need to screen more often. There would be a big difference in how often you'd screen someone with stage 3 CKD versus stage 4. You may want to consider someone monthly screening for eGFR with more advanced stage 4 disease, as opposed to less advanced stage 3 disease. Next slide, please. When do you refer to a nephrologist? This is one of the most complex things to a lot of individuals, because especially if you're in certain settings where your referral pattern being looked at, referral numbers, you're over referring. So you want to make sure that you're not over referring or under referring. So anytime that a primary care health provider is uncomfortable in taking care of any chronic kidney disease, and there's no colleague present that's comfortable with doing that. So everyone has their own level of expertise in managing every disease process. I always tell people, I don't need the smartest healthcare practitioner. The healthcare practitioner that I want taking care of me is when they know their limitation, because you can always go find out, go read about it. There's UpToDate, there's Medscape, there's everything. That's the most important thing for me in a healthcare practitioner. You don't have to be the smartest, but you do have to know your limitations. And that's when you refer. If the GFR is less than 60, for me, there's a strong consideration, especially if the provider is not skilled in managing secondary hyperparathyroidism. Less than 60 is when the wheels begin to get shaky and may threaten being thrown from the car, because you start to see lower vitamin D levels, increased intact PTH. When the GFR is less than 30, everyone should be seeing a nephrologist, no exceptions. And the reason for that is that's when you start to see advanced secondary hyperparathyroidism. You start to see bone mineral metabolism issues such as increased phosphorus, decreased vitamin D levels, and reduced calcium levels due to the inability to absorb calcium due to the lack of production of vitamin D. Remember, the liver does 25 hydroxylation of vitamin D that's generated by the sun, polycalciferol, or whatever you ingest. Vitamin D3, for example, in a supplement, is very important that the liver does 25 hydroxylation. Then it goes to the kidneys for 1 hydroxylation. So active vitamin D is 125 vitamin D or cholecalciferol. So also, that's when anemia really starts to set in, because guess what your kidney makes besides vitamin D? It makes erythropoietin. So if it's not being efficient making erythropoietin, the bone marrow is not going to be as efficient in producing red blood cells. Persistent urine albumin to creatinine ratio greater than 300. That's very, very important. Let's see. There's something in front of me here. All right. Or urine protein to creatinine ratio, not ration, but ratio greater than 500 milligrams per gram. All right. Next slide, please. And we are at the end. Questions?
That one, I figure we had a couple of extra breaks in there before questions. So please start chatting in your questions, but we'll also open your mics in a moment to ask them verbally, which is fine with us too. But before we do that, I want to launch our poll questions. And if you just take a moment to answer those. And our first one is wrong, so pardon that one. It's from last week. Here's our, this one's also from last week, goodness. So for some reason, my poll questions are not working this week. I apologize. So basically, chat in. I'm wondering if the poll question should have read, have you been using that first session materials as a conversation with your team? And also wondering if in that first session 1 materials or action plan, excuse me, did you take a look at who you are screening, and did you make any changes after what you learned last week? And now, of course, you're learning some more about it. So just take a moment and chat in, kind of, yes, we are now screening more people than we did before, or no, we didn't make any changes to our screening as of yet. So if you could just start with that, chat in your answer, and then of course, chat in some questions if you'd like. And we can open it up also to questions in just a moment. Okay, got a couple answers coming in. Why don't we go ahead to your questions? And then we will save a little time just to take a look at this week's action plan. And we have 2 documents to share with you today, as well as share with you the group area that we've shared with you. So we have about a good 5-10 minutes for questions. So if you'd like to open your mics, feel free.
And while everyone is thinking about it, I just want to reiterate, it's so important we not think that the only individuals to screen are diabetics and hypertensive patients. Again, there is a host of family diseases or inherited diseases that could be present. Sometimes someone in their 40s come in and you will pick up polycystic kidney disease by asking a good family history question. Anyone that you know had persistent blood in the urine or any family history of kidney disease. And then all of a sudden the history they begin to give you, you see it being generational. Or, so it's really important we don't get tunnel vision to thinking, oh, if you don't have diabetes or hypertension, you don't need to worry about it. Yeah.
So we have a question in the chat, and it is, have VIT-D3 always been low for people, or have we vitamin D3 always been low for people? Or, sorry, then the chat screen changed. Can you see the question in the chat? Or have we just started screening more?
I think we've just been more aggressive. I'm from Jamaica originally, but I've been in this country more of my life. When I screen my brother's mother-in-law, she lives in Jamaica, gets out in the sun regularly. There's not a whole lot of rain in Jamaica. And her 25 vitamin D level was 19, I think. And she's okay with me using it. I use it all the time. So I would say everyone on this call is vitamin D deficient, probably with the exception of 1.3 persons. And if you're not falling between 50 and 80, your 25 vitamin D level, you are vitamin D deficient. Why is that important? Vitamin D is necessary to absorb calcium, and calcium is necessary to absorb what? Iron, right? So it becomes a cascade. And if you don't absorb those things, weak bones, osteoporosis, anemia is very important. Even mild CKD is more associated with lower vitamin D levels. You don't have to have advanced CKD to have a problem with vitamin D or anemia. You'll be surprised how significant it is. So it's really important. I think everyone, if they've never had their vitamin D tested, everyone on this call.
I can tell you my own personal simple story is that I was never tested until I was in my upper 40s. And then they said, oh my, why have you never been tested? So I'm very thankful that particular doctor at the time said, let's test you. I was severely deficient in vitamin D. I now take that 50,000 unit dose weekly. And it really made a huge difference.
It's a huge difference.
And everyone take a look at the chat. Deb Bowie did type in some information for you to utilize. I think that's very helpful. Thank you, Deb. And I'm also going to quickly move to.
Was there another question in the chat?
Oh, it looks like 2 more just came in.
Yeah.
Or statements came in. Let's see. Annette's sharing her experience. And then also Annie says, I do not have a team that I'm working on with this specific to CKD, but I'm here for information and training. She's also going to share this with her partners. And
I like to say, when I started in private practice, my brother and I shared a desk in a very small office. in an 800 square foot office. That eventually led to about, from that to 8 locations. And he did pulmonary critical care, sleep medicine, internal. I did internal medicine, CKD. Then we added more doctors to the practice. But when we were in our infancy, we used check sheets a lot. We made little sheets that we call checkout sheets. And on the checkout sheets, we can do it a whole lot more sophisticated now, because when I eventually brought the practice to EHR, before I retired, we were able to put ticklers in the EHR to say, this is due, that's due, this person needs to be screened. But even if you have no team, no EHR, everybody has an EHR, but if you have no team, just doing checkout sheets, some key things, urine analysis, make sure urine analysis done, make sure they've been screened for CKD. Those little things can help, even if it's on a piece of paper, because everyone has a different private practice experience. But since everyone has to have an EHR, get with your EHR vendor to see how you can put ticklers in the system. Mm-hmm.
So Abigail mentions, will we be discussing screening and treatment of hyperparathyroidism? And I'm wondering, if we're not discussing it today, Dr. Campbell, do you think that next week, next session, Dr. Siegel may be discussing it, and that'd be something we can also have him discuss if you'd like.
That's fine. We don't want to go too in depth, because that can become so common. I did that for years with Amgen, the educational piece, and it can get, that's a topic in itself. But what we want the takeaway to be is you need to screen for secondary hyperparathyroidism. Primary hyperparathyroidism is when the glands are hyperplastic or enlarged and they make too much PTH, so therefore your calcium is high and PTH is high. Whereas the problem in secondary hyperparathyroidism is that your vitamin D is low. So your PTH is high because it's screaming at the body, you need to make more vitamin D, but it can't because of kidney disease. So your calcium is low. So it's the opposite, low calcium, high PTH. So what is the treatment for that? At the end of the day, it's treating your underlying condition for CKD and given the appropriate amount of active vitamin D, which will decrease your PTH. Because the higher your PTH, the more it beats on your bone, it demineralizes it. That's how it raises the calcium and phosphorus in your blood. So your bone becomes weakened. That's very important. So that's basically the treatment of it. Vitamin D deficiency leads to increased PTH, but the body can't do it very well. So you have low vitamin D. So the treatment is vitamin D and treat the underlying cause of the CKD.
Thank you. So there is a team here, and many of you are sharing Abigail's Zoom link, and I know some of you changed your names and some of you didn't, so I don't know if that was directed from Abigail, but
that was the real Abigail DeVries asking that question.
Okay, great.
And I emailed you to see if we could get some Zoom links sent out to the rest of the team so we can get there. But yeah, appreciate it. Thank you.
No problem. So thank you for that question. And if you'd like, would you mind sending me an additional email, just kind of a little bit more in depth about your question, because then I can send that back out to Dr. Siegel, who's coming next session, and also Dr. Campbell, and maybe we can get you a little bit more information to cover it. And then we will also know everyone else on the call that we will definitely share. Whatever we share with all of you, we will share, or someone individually will try to share it widely too. So that was an excellent question, and let us know how more we can help, and we'll see what our team of experts can do. Let me just quickly pull you to the session 2 action plan. And I just want to remind you all that as we send you the action plans, we are hoping that you're going to take a look at it, not only as yourself as a person attending this, but also take this back. And these are good, challenging ideas and questions for your practice or your organization to look at these areas. So as you can see in this particular action plan, we are challenging you to take a look at the risk and progression of CKD, very important. And we're asking you to take a look at what your goals are around these comorbidity areas and areas that we want you to be paying attention to. And then there's kind of a, hopefully it isn't coming across too pushy of a question, but you all know that each of your providers in your organizations, and also if you're here as just another organization supporting providers and clinics, you know that not everybody does the same thing across the board and that organizations set protocols. So, you know, at least consider this question number 3, you know, what are you doing about it? And then also map out your process steps, you know, to help those providers or your organization, you know, to work on goals for A1C and blood pressure. The other item that I would like to bring to your attention, and tell me everyone, did my screen change the Kidney Foundation?
Yes, it did.
Wonderful. So in this, we have a kidney numbers and the CKD heat map. We will get this out into the group area as well as send it out to you this week as we kind of follow up with you after this session, excuse me, today. And this is a great tool that might be helpful to you, brought to us by our partners at Midwest Kidney Network, something they found from another organization. But we also want to show you hot off the press. Dr. Campbell has worked a great amount of time to bring forward to you this new screening and diagnostics dashboard by GFR, and you are the first folks to get to see this. Dr. Campbell, do you want to just explain it just a little bit on the front page, and then I'll flip to the second page of it. And you're on mute. You're on mute. There you go.
Before I go into the dashboard, someone asked a question, is there a correlation between hypertension and CKD? Absolutely. It's the number 2 cause of ESRD. High blood pressure damages the small blood vessels in the filtering mechanisms, or the nephrons, the basic unit of the kidney. So your arteries try to block the excessive pressure coming into these filtering mechanisms, but it can only do but so much. And then there's the structural changes in the muscles of the blood vessels. You work those blood vessels harder, they're going to what? The muscles are going to clamp down, they're going to get enlarged, you're going to get damage to the blood vessels, you're going to get scarring, and eventually those tiny blood vessels are going to basically get scarred down and disappear. All right. I think
I'll bring it back up just 1 second.
Okay.
Sorry, I had to grab a link for all of you.
So there's a strong correlation between hypertension and CKD, and it is the number 1 reason Blacks or African Americans end up on dialysis.
Okay, the screen will now change back to sharing. We'll get you back there you go.
Okay. We wanted to create a screening and diagnostic tool or dashboard, just like you're flying a plane. You want to see the 50,000 feet view so you can keep the plane flying. So when the patient they're streaming through their office rapidly, you don't need to be bogged down with detail. Someone comes in, I'm just going to pick at random, stage G4, whereas the patient has, say, a GFR of 29. So what do I need to do? What screening and diagnostics? Okay, history and physical is going to always be there. So, but you do at that point need to get a kidney ultrasound, uric acid, 25 vitamin D, intact PTH. Why is it important, for example, to get a uric acid at that point? It's important because at a certain loss of GFR, you're going to start to see the increase of uric acid in the blood. and you're going to begin to see more gout. And of course, you want to screen for albuminuria. The other categories right there. Can we scroll back up for just 1 second?
Certainly.
Let me see those columns again.
Yep.
So, okay. So going back to the stage G4 and crucial comments over there. You need to A1C and albuminuria screen, because diabetics, you can pick up diabetics in this category. They don't give you, they don't give you a history of diabetes, but they may give you a family history of diabetes. They need to be screened for diabetes, all right? And then diabetics, they need an A1C, and they need to be told what to avoid, but you can see it here on the crucial comments, refer to nephrologists. And that's just a quick way when people are passing through. If it's documented in the chart, you could just know what labs need to be drawn. So if they've never had a uric acid and they're in that stage, you may say to the physician or the nurse practitioner or PA, say, look, they need a uric acid based on this dashboard. So that's the whole point for it. Scroll up a little bit for me. Let me see the bottom. And then you'll see they have blood pressure goals, which is very aggressive, less than 120. Let me say this, because this is the most important thing about blood pressure. If you're going to have those aggressive goals, you're going to have a standard way written in stone of how you check blood pressure. It doesn't matter whether or not you use a manual cuff or automated device, just as long as you choose one and there is a written protocol. The patient comes into the room, they're allowed to sit there for at least 3 to 5 minutes with no one speaking to them. Also, they should not have consumed certain things like, of course, drugs, but no caffeine within 72 hours. It's a very, very rigid protocol, and you have to stick with it. If not, you'll have to go to the higher goals, like 130 over 80 or less than 140 over 90. What are the caveats? Be careful of the frail, the severe elderly, greater than 85. I'm not going to say greater than 60 because it's about my birthday and I'm 60, so we won't say elderly for my category. But the severe elderly, such as greater than 85, we have to be careful. In individuals with cardiovascular disease, heart disease, but also severe carotid artery stenosis. All right. And then those are some pillars, and we call them the 3 Ds. Disease, which are the comorbidities, discomfort, and drugs. And you can read up on the different categories. As patients flow through your office, pay attention to the 3 Ds. For example, in the drugs, avoid NSAIDs and aminoglycosides. If someone still makes urine, even if it's a mil per 24 hours, if they're on dialysis, you still avoid NSAIDs even more than when they're on dialysis, and aminoglycoside, such as amikacin and gentamicin. You want to avoid those because even if they're making a teaspoon of urine per 24 hours on dialysis, guess what? They tend to live longer and have less morbidity as well. All right.
So what I'd like to do quickly, because we're almost at time, before we answer the question yet that's in the chat, what I would like to do is remind you all, please complete our evaluation today. I put the link in the chat. It's very helpful to us. Feel free to send me a direct email with any additional questions or things that you would like us to cover because we have many more sessions to go that we can get things covered. I apologize. We're going to take a look at that podcast/video that I sent out to you today, but I do encourage you to watch that, and we will try to work that in when Dr. Campbell comes back as one of our session leaders. Next week, I'd like to announce that, as Dr. Campbell mentioned, he's going to be celebrating something very special. He will not be our session 3 presenter, but we will have Dr. Siegel come, who is a nephrologist, who also has a really great perspective to share with you. So you will see him in session 3. And know that we will continue to send you out some pre-session materials as we go along. The other thing that we didn't get to today was, and I'll just send you a direct link, we do have a group area for you to join and be a part of. And it would be helpful if you come along in that group area, because you can then ask some additional questions of all of us who have created this collaborative for you, as well as ask questions of each other. So I'll send that direct link out to you later today. It was also in your pre-session materials, and thank you to those who have already joined. Last question in the chat, Dr. Campbell, is does skin color in dialysis have anything to do with health outcomes, or is that a liver health?
Okay. Skin color is a social determinant of health. I'm assuming you're referring to race / ethnicity. Yes, it does. Last year we did a talk at the CMS quality conference. We talked about those determinants. For example, skin color does impact how long you're on the wait list, if you get on the wait list, but also transportation, modality choice, individuals, Blacks and African Americans tend to be placed on home treatments less, whether it's home hemo or peritoneal dialysis or automated peritoneal dialysis. So yes, it is a social determinant in any chronic disease, not just CKD, but any chronic disease. I hope I answered your question correctly. I hope I realize where you're going. And we're at the top of the hour.
Yeah. So if you have additional questions, please feel free to directly email me. I'll be happy to get that to our presenters, our experts in this field. And if there's something that you definitely want us to cover in the next 4 sessions, we do have things planned, but we're able to make some adjustments as needed because we are coming here for you. So we want to thank you all for your attention today. It has been great having you here, and we look forward to seeing you in session 3. And thank you. This will end our event today.